placer estar acá compartiendo con
It's
ustedes.
been my pleasure to be here and share with you and to be part of all this. I feel like Messi, who moved from Barcelona to London, and I will speak about proximal bicep ruptures or tears. This is a topic that is a passion for me. And I think that the biceps has become very important lately, which it wasn't considered before. And I compare it to the impingement because we would operate on the impingement many years ago. But I think that now some of the pain in the anterior shoulder that we do not understand where they come from, the biceps has explained them, especially the long portion of the biceps. Biceps is a muscle, especially in its long portion, genetically for flexing. And in the case of the shoulder, it goes from upwards to downwards, from the back to the front. And that change in direction causes the biceps to form a major torsion that causes big stress. And that's where the arcoid fibers are there. And the other is that the traction creates forces above the glena. According to Failer, 65% of the patients with have pain in the anterior aspect of the bow of the shoulder have problems in the biceps, and that explains how some things can happen. And the alarm, the red flags that it is affected, the biceps, is the pain, the change in the disposition of the collagen fibers, the tears in the process or microinstability, and the changes in the architecture of the pulley, and lesions that are associated, things that are, for instance, difficult to see in the studies, for instance, fall, those that the overhead throwers suffer these, and this abduction in external rotation causes the stress to go especially to the upper part and the first trajectory of the 5 centimeters of the biceps. That's where normally the biceps suffers. According to the anatomy, the biceps is a point, it shares certain structures that surround it, and because of its characteristic, it's a point that has many collagen nociceptors and of the arcuate, and that makes it very sensitive point. It's not the same to get a blow close to the eye than in the eye. All the lesions that are close to the area of the biceps but don't affect it don't have a problem. For instance, tears of the rotator cuff, practically patients come anatomically normal and they don't affect, they don't have a pain. But when they start to affect the biceps, we find this conflict zone. The traction of the subscapular goes forwards and the others go in different direction. This generates conflicts, and this coincides with the outward side. And basically we have intraarticular lesions, we have the slab, the pulley, and associated to the breakage of the supraspinatus, and extraarticular, the bicipital area, slab, of course, the upper labrum lesion. We know it, so I will not speak about it. When it's grade 1, we just do the treatment and we do not operate on it. And then, yes, we try to do it. If it's a young patient, low demand, we try to repair them. And if it's an older patient, we directly go with tenoplasty. That's what we do in our service. This is the configuration we used before. Practically, it's no longer used, and we prefer this type of configuration. At the beginning, we would do this, that it just push the biceps from the top, and we try to leave the edge of the biceps free so that the elasticity and the traction of the biceps would not interfere that much. We are not saying that it cannot be done. When you do it from the top, it generates more pain, but after 3-4 months, it starts to work as it should. But if we can, we prefer to leave free the upper rim of the biceps. This is a post-op control. We have had cartilaginous slab the gap was practically not seen in the MRI, and we separated it. It was separated together with the cartilage or associated to Bankart lesions. We always think it's better to repair, especially in patients up to 40 years of age. And the second group of lesions are those associated to the pulley. Basically, there are four types: those that only affect the pulley, those that affect the pulleys and the supraspinatus, those that affect the pulleys and the infraspinatus, and those that affect the pulley in both directions. When there is, of course, a dislocation of the biceps, normally a large lesion of the biceps is associated to the subscapularis that pulls from it. So many times when we have a biceps lesion, we should think of a lesion in the subscapularis and vice versa. This place of the pulleys, and to me it equates the eye of the shoulder. So it's formed by the superior glenohumeral ligament and the progression of the subscapularis. In the MRI, it's difficult to see this place precisely, but there are indirect signs that tell us that there is something affected. Cyst, for instance, or edema, as you can see there. All this leads to suspect that there is a conflict area. Many times the biceps comes before the tear of the rotator cuff, because it is, and sometimes one is the consequence of the other. Sometimes it starts with a congestion, sometimes in the biceps, sometimes in the pulley, sometimes in both. Mechanical, a physical failure, and sometimes it happens the other way around. So the tears precede the mechanical instabilization, but you should suspect and you should go look for it. I am not speaking of saying that a biceps in this condition, you have to do an approach, a tenodesis, and the idea is to do a tenotomy or a tenodesis. I think that tenotomy is much simpler in the practice, but I think that a tenodesis is the right thing, because we have had patients referred to us and the only problem is a Popeye arm, and we have even had to operate on them. I think that the Popeye arm is not as innocent or as naive as we think, and I think that even if it's not painful, you have to bear it in mind. The place where to fix it varies, and we know that it goes all along the fixation sites of the biceps, and in all the washers, we know that if there is a change of the cartilage towards that bone, 1 centimeter in every direction. So we can move even 1 centimeter inside the joint without affecting a deduction or abduction. With respect to the type of implant, it's varied and it depends on the experience. We prefer anchors without sutures, and the evolution of the treatment in our service was this: we would do it open, we would fix with one of the methods, then we moved to a mini open and arthroscopy. Here we detached, you all know how this is done, and we would fix. Usually we would fix it open with anchors, or we could fix it with this type of biotenodesis screws. It depends on the characteristic and whatever we have available. That's where it's fixed. And what we have been doing lately is this type of surgery. And basically what we do is in lateral decubitus with the arm in abduction, which we think is the best anatomical position for the biceps to preserve its length. We fix the biceps. Here the technique shows that you first cut and then you fix. We prefer this type we prefer this type of fixation. And here we cut first and then we fix. Since we do it in lateral decubitus and in extension, we think that it can offer the chance of first fixating the biceps, fixating it, and then cut. This facilitates the practical work. We think that the result is the same. This is looking at the washer from inside the joint. This is a 70 optics, and this is a 35 optic as the one we use. So we mark the intraarticularly, we place the suture, we place a stitch like the one we saw in the scheme, and without cutting it, we fixate it in there, even up to 1 centimeter inside the cartilage. And we use two portals, an anterolateral and a superior. That's how we get in 90 degrees. And once we fixate the tendon, we leave it there. The third group that I said were those associated uh, to the rotator cuff. And what we do is that when we have a rotator cuff tear, it's important to go and look at the biceps, not because it might be torn, but sometimes mechanically the structure of the pulley is altered and you need to go and look it and fixate it where it should be. This is the last video, not very clear, sorry. So we prepare the bed, that is the biceps tendon there. We are placing an awl, and there we see the tear of the rotator cuff, that's the biceps. We place an anchor. We prefer always to place biodegradable anchors. That's our preference, but we know that maybe other anchors can be used. In this case, we place first the anchor because we are going to use the second suture to start suturing the rotator cuff, and with one of the suture, we do the tenoplasty. This is a lipinol. We grab it, we take the suture, and what we are going to do is tie a knot to do the tenoplasty and to come out from the bicipital groove. So the same thing we did from the intra-articular perspective, we are doing now from the outside. And if you have the suspicion that mechanically the biceps is altered, it would be recommendable to do the tenoplasty. With time, we have seen that many rotator cuffs in revisions have failed because this has not been done. These are the sutures we use for the biceps, and once it's tied, once it's fixed, with the arm, as I said before, in abduction, we cut the suture, and with the scissors, we cut the biceps tendon, then we burn it, and if there is any proximal remain, we remove it. This is the surgery that we perform in our service. This is what we do now, and thank you very much for your attention.